Hello everybody, I'm Stefan Anker. I was just attending the last 2 days the Guideline Forum on heart failure here in Nice. Great pleasure to chair this together with a few good friends, Andrew Coates and Peter Seferovic and Gerasimos Felipatos. The discussion they centered around the guideline processes and then of course about past recommendations made on drugs and on devices and guideline implementation processes in general, but then also of new developments, new therapies coming, and how this could look like in the future. So one of the interesting things, of course, was a big debate around the treatment of valvular disease in heart failure. And so maybe for me, what I learned best was the differentiation between the use of MitraClip in the context of patients looking like the patients recruited for COAPT and for MITRA-FR, and where maybe the differences in the studies are and what we can learn for possible future use of these therapies. But then compared this also to the ReShape-HF2 trial that we are organizing through a grant from Abbott Vascular, but as an investigator-initiated study through the University of Göttingen. Gerd Hasenfuß, who's presented here, and Piotr Ponikowski, who is the PI of the trial, and myself, I'm organizing this together with the team there in Göttingen. We had a chance really to present on this, and we learned that the population in ReShape-HF2 is probably really a different population than the two other trials. So we need the results of this trial to make a separate recommendation. Some people call ReShape-HF2 the tiebreaker. I think it will not be a tiebreaker. It will really provide, when it comes out in a few years, additional new information. The conclusions have to be made from the COAPT and MITRA-FR trial as they were done. There was a very broad discussion area also about comorbidities, ranging from the management of atrial fibrillation and sleep apnea, particularly central sleep apnea, then iron deficiency, where the different intravenous iron preparations available were discussed, and what the new information that will come from the morbidity and mortality trial can mean. Now, when you talk about guidelines, a very interesting aspect is also the implementation of the recommended therapies of guidelines. We know that, for instance, hyperkalemia is developing, and hyperkalemia prevents many patients to be on RASIs or to be only on suboptimal doses of RASI therapy. Now, there are, of course, 2 new potassium binders available, and here it was discussed how maybe in the future we evaluate these therapies if and when we know the results from the ongoing studies. Some of these studies have been completed, like the PEARL-HF trial. Other studies, like HARMONIZE-HF, are just in the starting phase and will report fairly soon, definitely before the next guidelines. So it's kind of interesting to see how this is shaping up. Now, there was a whole discussion point around the pure implementation of therapies, maybe only needing to soft recommendations. But of course we don't know this, and the guideline groups in the future should discuss this. But what would be important to get additional information on symptoms, on maybe even surrogates like natriuretic peptides, but possibly also, when this is done through hypertension trials, maybe also on blood pressure, before you then go into 6-minute walk test, symptoms, patient global assessment, to the big event trials that I believe are planned. Iron deficiency was in 2 different ways a topic for discussion here. One was the importance of blinding when you assess patient-reported outcomes, and there's a clear statement that when blinding is possible, blinding is a good thing. When you have similar studies, but some with and some without blinding, then blinding is preferable, and it was really considered a very good thing that the intravenous iron studies using ferric carboxymaltose are available in blinded format for testing the benefits on patient-reported outcomes. The second way of discussing the intravenous iron point was through morbidity and mortality trials and their possible influence on future Class 1 recommendation. And very clearly, if these trials are positive in the future, I believe that Class 1 recommendations will be warranted. The dialogue between different organizations on guideline processes, guideline content, I believe would be very nice to have. But we have to be honest, it's rather difficult with large political organizations with given processes that are how they are for the last 10 or 20 years. And then, of course, with bigger backgrounds of the physicians coming from endocrinology, diabetology, nephrology, but then also, of course, cardiology, as in our case here. So as important and good such a process would be, maybe the best area where this can really happen is in the methodological sense, patient involvement, the use of big data and registry information to shape future guidelines. This kind of more technical approach to harmonization of the approach on guidelines, that I believe is possible and would be very good.